Hello all. So we are at the venue of Epicon 2025. The work is in progress. So it is only 2 days left to officially inaugurate Epicon 2025. But we have two doyens in clinical medicine. We have with us Professor Udas Ghosh, Professor of Medicine at Medical College Kolkata, recently retired. And we have Professor Mrinal Kanti Rai, who was professor at Department of Clinical Medicine at Calcutta National Medical College, and he is also a doyen in the field of neurology. So let's today, in between the preparation of Epicon 2025, have some clinical medicine discussion. So let's requesting Professor Udas Ghosh to start the discussion.
Good evening. Now we will start a live case discussion. Actually, today one case was admitted under me in a private hospital. The patient was a male patient, 47-year-old, slightly obese, BMI more than 30, without any known hypertension, diabetes, or any habits. No diagnosed case of any dyslipidemia. Patient has a history that during a night at 2:30 a.m., when he was in the process of micturition in his bathroom, he suddenly rather fell down and had a history of trauma over the back of the head. After that, she already got up from this ground and went to his bed. And in the morning, when he woke up from his bed, he noticed that he has some nausea and with some drowsy state, so feels uneasy, some headache or like that. And she came to the hospital, and in the emergency, the RMO, resident medical officer, has seen the patient, and then he called me and giving this description. Now I ask our Professor Dr. M. K. Rai. So, sir, in this history, which patient came in the hospital, after taking this history, how do you approach in this patient?
Thank you, Professor Udas Gupta. You are also a very extraordinary clinician, especially in internal medicine in Calcutta. And I feel that the case what you have actually given to us is a very interesting case, because these types of cases are encountered often in our emergency by the EMO at the very outset, followed by this patient is examined by the treating physician or surgeon. So as the history suggests, during the process of micturition, that gentleman first time fell down. So my first provisional diagnosis will be whether it was a micturition syncope or not. But then you have to be very sure whether there was any history suggestive of any loss of consciousness prior to this fall or not. That is very important. If it is not so, this micturition syncope will come first, followed by any other differential diagnosis. Now, as the patient has got a history of next morning development of some sort of an uneasiness, dizziness, along with nausea and headache, all these features suggest that there is some point in favor of development of raised intracranial pressure or ICP. And in the background, probably when he fell down, that might be the most important precipitating cause, which might have caused some sort of an internal hemorrhage, and that has caused this problem. Now you have to remember that a stroke occurring in this background is not very uncommon. So in any circumstances, you will have to exclude three important things. First, I will take into account the micturition syncope, but subsequent history does not actually classify the very classical characteristic of micturition syncope. As you have developed the problems in the next morning, you have to do one CT scan at the very beginning to exclude any sort of an hemorrhagic problem, whether he has got a hemorrhage in a particular arterial territory, which may be due to a stroke, or he has developed this thing in the background of your fall, which may be a direct involvement of the various areas of the brain, maybe in the frontal lobe, maybe in the occipital lobe, maybe anywhere in the brain. That you'll have to find out. And not last but not the least, subdural hematoma will also come into the differential diagnosis.
So very good. Your analysis is very good, but you have clinically diagnosed the three possibilities, rather four possibilities. One is the micturial syncope. Second is the any cerebrovascular accident. Third is a complication of head injury, maybe any hemorrhage in the brain, or it may be due to subdural hematoma. So, before giving a discussion with these 3 points, let us see what I found on examination. On examination, other system or cardiovascular and other systems are more or less normal, but the neurological examination in DCA scale, it is a 15 by 15. There is no any alteration or any of sensorium, but there is no weakness in a motor power. But when I did the plantar examination, it has seen the plantar is off in the right side, or rather flexor in the left side. So this is the only clue that gives the patient have some neuro deficit. So probably it may not be a case of a micturial syncope. So either it is a case of CVA, cerebrovascular accident. What Dr. Rai has already said, the patient has developed CVA and then he fell down. And second is he fell down, then he had developed the complication of head injury. Sir, is there any clue to differentiate it, whether it is a stroke or it is a consequence of head injury?
Yes, there is no, in this particular case, actually from the history is very important, but the patient cannot give you the history as he was unconscious for a short period of time and he cannot remember what actually happened to him. However, after the examination of this patient, you can find out that there are neurodeficit. As he is neurologically stable in the next morning, what you have told, GCS is 15 by 15, only the plantar is upgoing in one side. So you will have to take about the consideration of a stroke in this case, because the plantar extensor is definitely a very hard sign after this type of story. So CBA is to be excluded, and that may be also in the background of what I have already told, that may be due to a head injury also. But regarding the localization, the differentiation between an hemorrhagic stroke and a very classical head injury giving rise to an intracranial hemorrhage, it's sometimes difficult, but if the classical site you have to look for, whether the stroke actually takes place in a very classical arterial territory, and whether in case of your accidental stroke or a stroke occurring in the background of a fall like that, or an injury does not maintain these types of arterial territory relationship. So it can occur anywhere, and it can sometimes may be contracope injury. It can even be subdural hematoma. It may be in the frontal lobe. It may be in the sinuses also can be involved. So these will give you the clue that it is not a very classical cerebrovascular accident. But when CVA takes place, if it is an hypertensive, we know that it is a ganglionocapsular region is very involved. Whereas in elderly people, some amyloid angiopathy, we can have a cerebral type of involvement. So these are the ways you have to distinguish in a short.
So thank you, very good discussion. But the patient is a young patient, 47 years of age, without any history of hypertension. Even at the time of examination, the blood pressure is 140 by 80 and CVG was 133. So with these clinical findings, so it may be, you have mentioned it is a hemorrhagic stroke, but non-hypertensive hemorrhagic stroke that may occur. And that is not a typical site of hypertensive hemorrhagic stroke what you have mentioned. So it may be the possibility of non-hypertensive hemorrhagic stroke. Another is the possibility of the head injury related contracope lesion in the opposite side, rather frontal lobe, if the patient has got a injury in the back of the head. So these are the two possibilities. Now we have done a CT scan of the brain, and CT scan shows there is a hemorrhage in the frontal lobe and in the right side of the frontal area of the brain. So, Dr. Rai, so now after seeing the CT scan report, the patient have a hemorrhage in the right part of the frontal lobe, just without crossing the, midline. So, what will be your impression in this case?
So I think it is due to the injury. First, my diagnosis will be it is due to the injury, because this is not a very typical site what you have mentioned in the arterial area, and also there is no leg weakness, there is no urinary problem, there is no mutation in this problem. So anterior territorial artery, these are the things usually we come across in anterior cerebral artery stroke, but it does not maintaining this area. So it is most likely due to the lower hemorrhage, which is due to the injury, head injury itself. But you will have to be very vigilant. Sometimes we can be befooled by these types of presentation, but we will have to take into consideration the other risk factors, like you will have to do one EEG, because he is giving a history while he was passing the urine, whether he fall earlier and there was an epileptic episode and then followed by that micturition syncope, what we are actually dealing with. But probably it is not a micturition syncope, now it is clear. So are other factors what we have already discussed about, like his BMI was high, you told that he is an obese person, so other essential risk factors is to be taken into consideration for secondary
Okay,
prevention.
that's a very good. So, so it is probably
And
due
consult
to
the neurosurgeon.
it is also due to the, effect of the head injury that I mentioned. It is not looks like a typically of rather a epileptic fit occurrence. So you have to do an EEG. So what other investigation you like to do to confirm your diagnosis, whether this is due to head injury or this is due to a non-hypertensive hemorrhagic stroke in the frontal lobe?
You just observe the patient for some time and consult a neurosurgeon, see whether he is developing any deterioration in his clinical symptomatology or not. And if you find that there is any problem with the raised intracranial feature, is developing gross amount of midline shift or something like that, then you have to think that it might require some neurosurgical intervention. The classical site you have mentioned is not very difficult for accessible to a neurosurgeon. So in that situation, I think you have to take a consideration of the neurosurgeon. And number three, never forget about the taking the history of the drug. Whether he was taking any drug which can make the blood very thinner. So any blood thinner, whether he was taking or was advised by somebody, sometimes it is very commonly
He is not
missed.
taking any drug thinner.
So that is very important to remember. So
Now,
if you
what
find
investigation you want to do? Do you do a MRI of this brain or MR angio?
in this case, if you suspect a case of cerebrovascular accident, then you should go for an MR angiography. Obviously, it is very, very important. And even if you can go for an DSA in this case, digital subtraction angiography, because sometimes this can give you an idea about the local area of involvement. But this age and all these things, just wait and observe. After sometimes if he deteriorates, then you go for the further investigation. Otherwise, a CT scan, a repeat CT scan after 72 hours or maybe after 7 days, if there is no deterioration, will help you to come into a conclusive diagnosis.
So we should do a conservative management in this case. That depends upon the what is the amount of hemorrhage. But Dr. Rai, what's your final diagnosis? What is the cause of syncope here, and what is the after head injury, this is due to the effect. But what is the cause of syncope? Is it if it is due to the head injury effect, why is the cause? Is it a micturical syncope resulting in head injury and causing this cerebral concussion or
Very nice question. Very nice question. Because at the very beginning, I have told you that the gentleman was absolutely all right and he fell down, and during the process of passing urine. So at the first, your diagnosis will be a micturition syncope, no doubt about it. So that's why I told you that you should go for an EEG in this case. If you find that the patient has got an abnormal EEG, so the in micturition syncope, the EEG are usually normal. If you find that he has got an abnormal EEG, in the with this history of passing urine during this process, then you will have to take into consideration probably the patient was having a seizure disorder. You have to give the anti-epileptic in this case, no doubt about it.
So, apart from that, so it may be a case of epileptic focus, or it may be a case of a micturition syncope. But after this head injury effect, as the patient is having a hemorrhage in the right part of the frontal lobe, so what will be the management? Do you require anti-epileptic drug or anti-convulsion drug here, and other apart from the other management of raised intracranial tension?
So you can give the prophylactic therapy. So far it is if the patient develops a seizure in this situation, then it means that the patient has got a symptomatic seizure. Actually, the development of a symptomatic seizure or acute symptomatic seizure is within 7 days of the injury. We call it as an acute symptomatic seizure. And at that point of time, you will have to start with the anti-epileptic
So
therapy.
which anticonvulsant
Number
drug
one,
should be
no,
given?
because if he develops convulsion, but if he does not give any, he does not develop any convulsion, then you can wait for some time to see whether he is developing or not. Otherwise, they do not need. But some of the neurologists or some of the neurosurgeons, they routinely use anti-epileptics in this situation. And probably nowadays, levetiracetam 500 milligram twice daily is sufficient enough to give you the good idea about to control the situation. And
Okay.
prophylactically, you can use the levetiracetam 500 milligram BD in this case.
So thank you, Dr. Rai. So we have a good discussion about this. So it's a very good, nice case discussion. Thank you, all the listeners.
So thank you all. So from the Epicon 2025 ground, we are talking about some clinical medicine. So hopefully we will get you all in 23rd of January. Thank you.